Medical ethics and bioethics are much more than a set of rules or recommendations. They are the foundations upon which a truly responsible clinical practice is built. In every medical decision, there is something more than science. There are people, there are contexts, and there are consequences that go beyond the clinical result. Therefore, both medical ethics and bioethics offer us frameworks for reflection. They help us ensure that, beyond knowing what can be done, we know what should be done. In this class, we will explore the fundamental principles that guide us when decisions become complex. To act always in the patient's benefit? Of course. But what happens when that benefit comes into conflict with the patient's own will? Or when we have limited resources and must decide who to prioritize? This is where the four key principles come into play: beneficence, non-maleficence, autonomy, and justice. We will also talk about the Lex Artis. This concept serves as a technical and legal guide to act with responsibility and within the limits of professional practice. This topic is not intended to be a theoretical introduction to ethics. It is, rather, a practical guide, a compass, so that you, as future doctors, can make clinical decisions that are informed, empathetic, and ethically justified. Medical ethics is built upon four great pillars: beneficence, non-maleficence, autonomy, and justice. These principles, although they sound simple when named, are the result of decades of ethical reflection and clinical practice. Beneficence asks us to act in favor of the patient's well-being. Non-maleficence, to avoid any unnecessary harm. Autonomy, to respect the patient's capacity to decide over their own body. And justice, to ensure that resources and medical care are distributed equitably. These principles are considered universal, but that does not mean their application is automatic or simple. Every clinical case is different. Every patient has their history, their values, their fears. And that is where these principles must be contextualized, weighed, and sometimes even enter into tension with one another. So, how do we know which principle should weigh more at a given moment? That is precisely the function of ethical clinical judgment. It is not about following a rigid manual, but about analyzing, deliberating, and acting with responsibility. In the following slides, we will explore these principles one by one. Not only what they mean, but how they are applied in real life, in the hospital, in the office, and at the patient's bedside. When we speak of beneficence in medicine, we speak of acting in favor of the patient, of procuring their well-being in every sense: physical, emotional, social, and even spiritual. This principle is not limited to curing. It also implies preventing diseases, alleviating suffering, and providing support during difficult processes. Sometimes it even translates into something as simple as dedicating time to explain a diagnosis well or listening with attention. But beneficence is not a generic act of goodwill. It must always be based on the best available scientific evidence and, above all, on the circumstances and values of the patient. Not everything that is medically possible is necessarily the best for every person. A very important point: doing good does not always mean doing more. Occasionally, a less aggressive but equally effective intervention is the most ethical option because it respects the patient's quality of life. Let's think of an oncology case. An oncologist might propose a conservative treatment, not because they are less capable, but because they have considered the adverse effects, the family context, and the patient's will. That is also beneficence. Now, what happens if the patient rejects the option that the doctor considers the most beneficial? That is where autonomy enters, and that is where this principle, as we shall see, must coexist with the others. The principle of non-maleficence brings us back to a classic phrase in medicine: primum non nocere, that is, first, do no harm. This principle does not only oblige us to avoid errors or negligence, it also calls us to prevent any unnecessary harm, even if the treatment is technically well indicated. Modern medicine possesses powerful tools, but that also means that every intervention must be critically evaluated. Do the benefits really outweigh the risks? Are we doing more good than harm? Sometimes in our desire to help, we can fall into excess, and that is where non-maleficence reminds us that not everything technically possible is ethically acceptable. For example, let's think about chemotherapy administered in very advanced stages of cancer when it no longer provides clear clinical benefits. Instead of helping, it only generates suffering. Suspending it in that context can be a deeply ethical decision. Non-maleficence also covers the technical aspects: guaranteeing asepsis, avoiding medication errors, monitoring adverse reactions, maintaining a safe environment. In other words, it is an ethics that is practiced from the most clinical to the most human levels. And as we mentioned before, this principle is not opposed to beneficence. They complement each other. One guides us to do good, the other to avoid harm. The principle of justice confronts us with a difficult but inevitable question in clinical practice: how do we distribute health resources fairly? Because justice does not mean treating everyone equally. It means treating everyone according to their real needs, based on objective and ethically valid criteria. This principle becomes especially relevant in contexts where resources are limited. For example, To which patient is an intensive care bed assigned when only one remains available? Who receives an organ for transplant? How is it decided who should be treated first in a saturated emergency room? Justice demands that these decisions be made with clear, transparent, and proportional criteria, not due to favoritism, social status, or external pressure. It also reminds us that some people, due to their social, geographic, or cultural condition, require an additional effort to receive equitable care. We are talking about rural communities, people without social security, and groups in vulnerable situations. An example that illustrates this principle well: implementing a telemedicine system to connect patients in remote areas with urban specialists. That is applying justice, balancing conditions so that everyone has access to health. And as a legal framework, it is worth remembering that Article 4 of the Mexican Constitution guarantees the right to the protection of health. It is not just an ethical aspiration, it is also a legal requirement. The principle of autonomy marks a profound shift in the doctor-patient relationship. For centuries, it was believed that the doctor should decide for the patient under the idea that they knew what was best. Today, however, we recognize that the patient has the right to decide over their body, their treatment, and their life, provided they have the capacity to do so. Autonomy does not mean the patient decides alone. It means they decide informed and accompanied, based on clear, honest, and respectful communication. That is the purpose of informed consent, which should not be seen as a simple document to be signed, but as a process of dialogue. That is where the doctor explains the risks, benefits, alternatives, and the patient chooses freely. But what happens when the patient rejects the treatment the doctor considers necessary? That is where tension arises. But if the patient is competent, their decision must be respected, even if it goes against medical judgment. That is also clinical ethics. Now, there are limits. Autonomy does not give the right to demand the impossible, nor to force the doctor to act against the Lex Artis, standard of care. And there are cases, such as with minors or people with cognitive impairments, where autonomy is delegated to family members or guardians, always seeking the patient's benefit and respecting their advance directives if they exist. In summary, respecting autonomy does not weaken the doctor. On the contrary, it strengthens them as a professional who listens, who explains, and who accompanies with respect and humanity. Up to this point, we have analyzed each principle separately, but the reality is that, in clinical practice, these principles are rarely presented in isolation. Rather, they usually interact, overlap, or even enter into conflict. And it is in those moments where the physician must exercise not only their technical judgment, but also their capacity for ethical deliberation. Let's consider, for example, a competent patient who rejects a life-saving intervention. Do we respect their autonomy, or do we prioritize beneficence by trying to persuade them? How far does our duty to help extend, and when must we stop so as not to infringe upon their liberty? These conflicts are not resolved with automatic formulas. They require a case-by-case analysis, with sensitivity, with prudence, and with listening. And often, they also require interdisciplinary support, for example, from a hospital ethics committee. There is no single correct answer, but there are more responsible paths. Clinical judgment is not just a matter of experience, it is also a reflective and ethical act. And if these conflicts are inevitable, that is not an error. It is a sign that medicine remains, above all, a human profession, where respect for life and dignity is not reduced to norms, but cannot ignore them either. Ethical dilemmas are situations where two or more principles come into conflict, and any decision we make implies a moral cost. There is no perfect way out. There is no completely satisfactory answer. This is where a fundamental concept for medicine and law comes in: the Lex Artis. But what exactly is it? The Lex Artis is not a law written in a single place. It is the set of technical, scientific, and ethical rules that govern good medical practice. It includes clinical evidence, official norms, accumulated experience, and yes, also ethical principles. When we face a dilemma, for example, the refusal of a transfusion by the parents of a minor, it is not enough to say, "I believe this is the right thing to do." One must act in accordance with the Lex Artis. And if that implies going to a judicial authority to protect the child's life, then it is done. Because the doctor not only answers to their conscience, but also to society and the law. Applying the Lex Artis does not mean following a rigid script, but it does imply a commitment to quality, ethics, and legality. It is acting competently, carefully, and professionally. And most importantly, it is a tool to protect both the patient and the doctor, because when a difficult decision is made based on the Lex Artis, it has technical foundation, ethical backing, and legal legitimacy. Making ethical decisions is not a matter of intuition or good intentions. It is a process that demands rigor, sensitivity, and structure. Therefore, here we propose a sequence of steps to face clinical ethical dilemmas with the backing of the Lex Artis and with full professional awareness. First, the ethical dilemma must be identified. Recognizing that we are facing a conflict of values, where there is no obvious solution, is already a fundamental step. Second, we must evaluate the clinical state and the context. Who is the patient? What is their condition? What does their family want? What other social or institutional factors are at stake? Third, comes the dialogue with the patient and their family members. It is not just about informing, but about listening, understanding their values, their priorities, and their fears. Fourth, if the case warrants it, consult with colleagues or with the ethics committee. Shared decisions tend to be more reflective, more balanced, and more defensible. And finally, document the entire process and the final decision. Ethics is also written, and it is written in the clinical record, with clarity, with honesty, and with professionalism. This model is not intended to be infallible, but it is a tool that allows us to act prudently, justifiably, and respectfully toward the patient's dignity and our own medical vocation. Because in the end, an ethical decision is not just one that seeks the good, it is the one that seeks it with responsibility, transparency, and respect for human life. Medical ethics and bioethics are not mere embellishments of the clinical act. They are not just another subject in the curriculum. They are, literally, the foundation and the limit of medicine. Because it is not enough to know how to diagnose. It is not enough to master the clinical guidelines. One must also know how to deliberate, recognize dilemmas, respect decisions, and act in accordance with the Lex Artis. Solid ethical training allows us not only to identify what is right or wrong, but to understand why and how to act in the face of life's real complexity. It prepares us to respond with humanity, to defend the patient even when they are unconscious, and to sustain ourselves in our profession even when the environment is adverse. And that is not learned only in the classroom. It is formed in practice, in the hospital corridors, in difficult decision-making, in conversation with colleagues, and in consultation with the ethics committee. Clinical ethics does not always provide clear answers, but it does teach us to ask the right questions, and it gives us the framework to justify our decisions when medicine, the law, and life require us to act. Respecting the Lex Artis, applying ethical principles, and maintaining a reflective attitude not only distinguishes the competent professional, but the truly responsible one.